go ahead and get started while people are still coming in. My name is Matt Kennedy. I am the Director of Healthcare Research at the Bipartisan Policy Center. And I'd like to welcome you all to the first policy forum in support of the Leaders Project on the State of American Healthcare. Just a quick mention on the Bipartisan Policy Center, or the BPC as we call it. It was founded a little over a year ago, a new organization founded by former Senate Majority Leaders Baker, Daschle, Mitchell, and Dole. And it's meant to be a place where we can kind of push aside the political discourse and really focus in on the tough policy challenges facing the nation. And of course our goal is to come up with solutions to those challenges that would be appealing to both Republicans and Democrats. And so what we feel kind of sets us apart is that we really focus on the substantive work behind those solutions, but we also place a strong emphasis on advocacy as well. And so we work within the political system to try to implement the solutions that we've put together. So when we founded the organization a year ago, the four leaders got together and they decided that they wanted to pick one issue that would kind of be their signature project, and they chose healthcare, and that's what brings us here today. Before we get to the main event, I just want to make a few notes on logistics. We have a really full agenda today, and so we're not planning any formal breaks, but it's a pretty informal setting. We still have breakfast out in the back, restrooms, so feel free to filter in and out as you need to. We are going to do our best to try to engage you all in the discussion. We have some really great panels put together today, and our panelists have put together some really great presentations. So we're going to do our best to engage you in the discussion. I hate to say it, we had Oprah Winfrey lined up to be here today to kind of field questions from the audience, but since the Democratic primary doesn't seem to be able to resolve itself, she's back out on the campaign trail. So we have what we think is the next best thing, which are note cards. And they're in your seats. If you find a BP staff person, we're kind of lurking about in the back. If you want to hand them the question or comment, we'll do our best to try to integrate it into the discussion up on stage. If we don't get to it, we'll certainly hang on to them and try to account for them as we move forward with our work. And I do just want to make one more final note. We wouldn't be here today without the generous support of the Robert Wood Johnson Foundation. They are our funder for this project, and I know we have some folks from, Andy Hyman is here representing RWJ. I just want to thank them. They've been really great to work with, and we really appreciate all their support. So with that, I'm going to turn it over to the host of today's forum, Senator Tom Daschle.
Well, Matt, thank you very much. I think I'll just speak from here, but I join Matt in welcoming all of you and welcoming our very distinguished panel. And I'm very pleased to be hosting the first Bipartisan Policy Center Forum in support of the Leaders Project and the state of American healthcare. I think it's going to be a very productive day, and I want to thank Al Engelbert in particular for coming and recognizing the commitment to meaningful health care through the establishment of the Engelbert Center for Healthcare Reform at the Brookings Institution. And also I want to thank the Robert Wood Johnson Foundation as well. They've been extraordinarily generous and helpful in our partnership with them to make this project a reality. Just last week, my colleagues, Senator Dole and Mitchell, formally launched the Leaders Project, and I can say on behalf of the four of us, including Senator Baker, that we are very excited to get this critical effort underway. So this is an important beginning today, and we're so pleased that you could be here with us. Reforming the nation's healthcare system is something that's long overdue. We can no longer afford the status quo of rising costs, uneven quality of care, and increasing number of uninsured, and the American people are demanding better. To meet this challenge, my colleagues and I committed to developing a slate of politically viable policy recommendations that the Congress and the next administration can use to reform our system once and for all. Over the course of the next several months, we will be exploring the topics, or pillars as we refer to them, that will ultimately serve as the substantive foundation for those recommendations. The topic we've selected for today's forum, improving the quality and value of health care, is one of the most often overlooked in the broader health care reform debate. We're all aware of the pressing challenges of skyrocketing costs and growing numbers of Americans without health coverage. But to effectively address those problems, we have to fundamentally change the way we deliver care in this country, building a system that provides the highest quality care at the best value. issue of cost and quality are inseparable, and I believe we can, as a nation, improve the quality of care while generating better value in the long run. So the group of presenters that we have today have already spent a good deal of time thinking about improving value. Each of them, from their unique roles in the healthcare system, have devoted a significant time to this issue. We'll hear about the specific efforts they have undertaken to improve both quality and value in the delivery, and how we can apply the lessons that they have learned more broadly across the healthcare system. I am certainly not the expert that each of our panel members are, but I've spent a good deal of time over the last 25 years on this issue, and my own view about value is that it really is a function of cost, access, and quality, that they are inseparable. And as we look at improving value and improving quality, that we've got to understand the inseparability and the intricate link that these components have. And if we're going to improve quality, that there are a number of steps. I only speak for myself in this early stage of this process, not for my colleagues or not even for the BPC. But I don't think we can achieve better quality without universal coverage. I don't think we can achieve better quality without recognizing that a lot of us don't have insurance access, at least, to dental care, to mental health care, or to long-term care. We often think of access in terms of our insurance coverage for physical care. But I think we have to look in a much more comprehensive way at what access we have as a result of the insurance coverage we've created. We have to put a lot of effort, a lot more effort on wellness and not on sickness, and a lot of people have talked about that. I'm troubled by the fact that I believe our healthcare system is the least transparent of all of the economic sectors within our country, and we have to work at improving transparency. I believe we have to establish best practices. I'm a pilot, and many who have flown most of their lives understand the importance of checklists. We've already established in healthcare delivery that checklists and best practices can save lives. We have to improve our access to information technology. I'm always amazed at the irony between the 21st century ability to deliver health care and the 19th century ability to manage health care with our administrative practices in it today. Pooling is an important aspect of improving leverage and improving, therefore, quality. Dealing with what I like to call proprietary medicine and our payment models. Our payment models are not episodic, they're by procedure, and we've got to change the payment model if we're going to improve quality. Better use of providers as well. We put too much emphasis on doctors and not enough on nurses and alternative providers, and nurses can play a lot bigger role than they do today. And finally, I believe we have to have some integration of our public and private systems, some way with which to make decisions more effectively than expecting my former colleagues, the members of Congress, to do it. And I believe a federal health board would allow us to improve quality. But again, I emphasize I only speak for myself, and these are ideas that I put on the table with the hope that we can talk about them throughout this entire process. So before we go to our first panelist, I'm extremely pleased to have our two co-directors with us today. They are experts in their own right, recognized as such. A dear and special friend of mine, Chris Jennings, somebody with whom I've worked for many, many years, and Dr. Mark McClellan, with whom I've also worked, are here as well to guide this project, and certainly will be instrumental in bringing us to our ultimate decision-making and the results that we hope to achieve through this effort. They are here and they will have opening remarks, but I might also note that our first panelist was scheduled, as most of you know, to be Dr. Peter Orszag, the current director of the Congressional Budget Office. Unfortunately, he was in a train coming from New York today, and the train ahead of his train was involved in an accident. So he is fine, of course. It's a very unfortunate set of circumstances, but as a result of that, it now appears that he will be unable to join us. So as I understand it, both Chris and Mark are going to provide us with some of the details of his presentation, and they know it well, and I know that they can handle this new responsibility just as well under these circumstances. So let me first introduce Chris Jennings, and then Mark, and we will begin with our panelists.
Thank you, Senator. It's really a pleasure to be here for our kickoff event for the Bipartisan Policy Center. You know, one of the great privileges of serving in the capacity that Mark and I currently do for the BPC is to work under Senator Daschle. There's not a person who clearly has more of a commitment or passion for this cause, and it really is a privilege to do that, Senator Daschle. His book, Critical, is just his latest example, and if you haven't read it, I certainly commend it to you. I was talking to some of the people who will be testifying today, and they certainly have. Really, if there is a better example of a need to improve our healthcare delivery system to ensure better quality and value, I know not what it is. And Senator Daschle's continuation of his public service by this latest offering is really an inspiration to us all, and I think it's a call to action. Let me just say that it is a privilege to work for Senator Daschle, but also Senator Baker, Dole, and Mitchell, primarily because of their longstanding commitment to this issue. They're knowledgeable not just on the substantive level, but on the political process, which I think will be very, very key as we move forward. And one area, because frequently Mark and I know Senator Daschle has asked, well, what is different now that was not the case several years ago about why people want to talk about healthcare reform? Why is suddenly there's so much interest and engagement? And you've heard all the usual discussion points about, you know, the business community is more engaged, both small and large. You're seeing the patient advocacy groups who traditionally, like heart and cancer, who focused on research, saying, no, I can't access that research findings if we don't have access to those care. And we see religious groups now coming together, both right and left. We see so-called strange bedfellow coalitions forming throughout Washington. I mean, it really is. You can see it, you can hear it, you can feel it. It's very palpable. But one area that clearly is unique now that wasn't, I think, in existence in 93, 94, was this real concern about and commitment to greater value in the healthcare system. A recognition that we can't even afford what we currently have and what we know we will have if we don't change how we deliver care in this country. And by the way, it will be very hard to ask for greater investment, federal investment in healthcare, if there's not greater confidence that we have more value in this healthcare system. And really that's what today's meeting and forum is all about, to highlight that issue in meaningful ways, not just to talk about, you know, this issue in general, but to look at very specific instances of successes in this area, to highlight those as well as barriers that currently exist to maximize those successes, and then to seek guidance about how we can move ahead in developing federal policy recommendations by the 4 senators at the conclusion of the presidential race at the end of this year. Now, people outside of Washington and many inside it as well really don't know or get the significance and sometimes dominant role of the Congressional Budget Office and what it plays in the healthcare reform debate. They are the analytical and budgetary impact referees for the Congress and frequently the press. Their assumptions and analysis, whether accurate or not, frequently play the pivotal role in policy changes and political viability. We are so unfortunate, therefore, to have a CBO director who understands how important their role is and will be to the healthcare debate. I know Senator Daschle and Mark join me in commending Peter Orszag in his commitment he has made in the healthcare reform issue. Many of you have seen his show, his slideshow. Many of you, if you haven't, you're about to. He well recognizes that staff and analytical resources at CBO are going to play a major role in the inevitable upcoming debate and he is doing all he can to increase CBO's capacity in this regard. And we thank him for that, as well as his excellent presentation. So today, Peter is going to morph into Mark. And Mark is going to be largely Dr. Orszag. I'm going to comment from the side if I feel so inspired. But we thought rather than having two people become Peter, it's better to be Mark, and certainly Mark is more qualified to do that anyway. So Mark, I'll turn it over to you. Thank you.
Thanks, Chris. I think I'm more qualified probably by virtue I've seen the slideshow the most times in here. But before I do that, I want to thank all of you for coming this morning. This is a really critical event in the process for the BPC effort. It's owes to the leadership of Senator Daschle, along with Senator Baker, Dole, and Mitchell. This is the first of the forums in a BPC set of forums that are going to cover the major pillars of health care reform that were laid out in the BPC's announcement last week. And there's a reason why we're starting with this emphasis on quality and efficiency and value improvement in the healthcare system. As Chris said, what I think too is different this time around is that healthcare reform can really be about reforming health care, not just trying to somehow make our current system, which falls short, has so much potential, but falls short in so many ways, not just making it, trying to make it more affordable. This emphasis on quality and value is growing, not just in this meeting, though we're trying to mark that very clearly here as this whole process gets underway. We're not the only ones saying this. It's an increasingly bipartisan issue. If you listen to the presidential candidates, Senator McCain has made very clear that a critical step in making health care affordable for everyone is improving the cost and making health care work better, with the same emphasis on prevention, on better quality, on coordinating care better, that Senator Daschle has been talking about so eloquently in his book. On the Democratic side, Senator Obama and Senator Clinton have both talked about the need for quality improvement and greater safety, and building on steps to promote health IT and other ways to make our healthcare system more efficient and transparent. In our own work at the Engelberg Center for Healthcare Reform at the Brookings Institution, we are undertaking a number of collaborative, broad-based efforts around measuring quality, reforming payment systems, reforming benefits, improving evidence, and promoting better innovation. All of the coalitions that have supported our efforts to date and with whom we're working very closely, the Strange Bedfellows that Chris mentioned, have made an emphasis on quality and value a key part of their efforts as well. But what I think is also going to come through today is that many of the key participants in our healthcare system are not waiting for federal policy action to address this challenge. You're going to hear today from a broad range of leaders and a broad range of initiatives led by physicians, by nurses, by pharmacists, by other health professionals, by consumer groups, by employers, by insurers, by other organizations in our healthcare system who believe that this is so urgent and so important for the well-being of Americans and the sustainability of our healthcare system that they are moving ahead. And many of them are having some promising results already. So what we want to focus on today is what can be done as we move forward with a broader healthcare reform effort to make sure we are avoiding unnecessary costs and closing those big gaps between how well our healthcare system actually performs today and what it could achieve for all Americans, and particularly those with limited means, those with great healthcare needs, those with chronic diseases, and those who are struggling with affording high-quality healthcare today. We're going to be very concrete, very application-focused, and if you want to think of how this fits in with the overall project, we're going to be building up from what is happening now without real clear support from federal policies and federal health care reform, and talk about what could be done in federal reforms to make these efforts expand and succeed and work much more effectively. So this is very reality-based. This is not theory. This is not something that's a transformation that's going to be imposed from outside. This is starting out with what's happening right now in our healthcare system that gives us a very strong bipartisan foundation to build on for healthcare reform. And as Chris and Senator Daschle said, I'm going to start this process by doing my Peter Orszag impression. So I am going to go stand up to do this. And as you heard,
I guess one way to think about this presentation is, as you heard, Peter was headed for a train wreck this morning, and maybe that's a good image for what we are going to be talking about in his presentation. Many of you have heard Peter speak eloquently. He has made the issue of healthcare costs and the need to reform healthcare delivery a key part of the CBO agenda, and vastly improves its efforts to support reforms that focus on these improvements in the healthcare system. And so we're going to talk a little bit about Peter's emphasis on capturing the opportunity to address what is, in his view, I think correctly, the nation's core fiscal challenge. And many of you have seen these kinds of slides before. What this slide shows is the percentage of GDP, actual and projected, going to Medicare and Medicaid. That's the top light blue section, the Medicare and Medicaid entitlements, to Social Security, and to all other projected spending in the federal government. And key point here is that the lines other, if you look out in the projections, the lines other than Medicare and Medicaid are relatively flat as a percentage of GDP, but the Medicare and Medicaid lines are singularly responsible for making the share of fiscal outlays in this country go from about where it is today, around 18 or 19%, up to close to 40% by 2082, a steady increase with a big increase coming starting right away. This excess cost growth, as Peter likes to call it, of cost growth above rate of growth in the GDP, is clearly and increasingly due to Medicare and Medicaid. You can see that from the numbers on this slide, with Medicare and Medicaid in over this very long period, 1975 to 1990, 1990 to 2005, with a slowdown in healthcare cost growth in that period was a little bit less, but overall consistently running for the last 30-plus years about 2.5% ahead of GDP growth. And there have been a number of studies that have broken down what accounts for that so-called, as Peter labels it, the excess growth in costs. The main thing to focus on is the bottom line in this table. There are a lot of factors. The aging of the population contributes. Changes in third-party payment basically means estimates of how much the fact that more dollars are paid by third-party payers rather than by consumers themselves contributed. There has been some role in price growth. I know that gets a lot of attention, but doesn't account for most of it. Administrative costs have accounted for a bit of the growth, but not a lot. The big number is the bottom number, which Peter calls technology-related changes in medical practice. I'm going to talk about that a little bit more. And by the way, just a reminder, I'm being Peter here, so this is my efforts to channel what he would say, and not necessarily what is the right term? Not necessarily endorse or agree with each particular statement, but I do strongly support the raising this issue of cost sustainability as part of our reform efforts. And as Peter points out, a lot of the discussions have focused on aging of the population and demographic changes as being a big worry, especially as the baby boom approaches prime entitlement eligibility years. But as the previous slides clearly showed, most of the problem is due to the rising costs of Medicare and Medicaid benefits per beneficiary, not the number of beneficiaries or the age of the beneficiaries as well. So if you look forward to the consequences of all this, that increasing share of federal spending, increasing share of GDP related to Medicare and Medicaid is primarily due to this excess cost growth, and this excess cost growth in turn is mainly due to changes in the treatment of patients in the Medicare program, not to aging, and not to other sorts of factors. You're being awfully quiet. I know if,
no, as long as you're doing great, just assume I agree with everything you're saying.
Okay. So if you look at the fiscal consequences of this, this is basically federal debt projections, which are a function of deficits over time, and as you can see, those are getting considerably larger, projected to get much larger as a result of the kinds of Medicare and Medicaid projections that we've just been talking about. And again, effective aging here is not a very large component of the total spending. It's mainly due to technology. I should say that there have been some other studies that have tried to look at within what's called technology here, how much of that is related to diagnosis, to the conditions people have versus how intensively those conditions are being treated. Ken Thorpe, who's here in the audience today, I hope we'll have a chance to talk a bit more about that. But the point is that patients are being treated more intensively, and that's the main reason why costs are, why these excess cost projections exist. Within that, though, every challenge presents an opportunity, and there does seem to be some evidence that we could reduce some of these excess costs, as Peter calls it, without impairing health outcomes and maybe even improving health outcomes in the process. Many of you have seen this signature slide from Peter. It's drawn from work by the researchers at Dartmouth College, led by Jack Winberg and Elliot Fisher, showing the variations in per beneficiary spending in Medicare from area to area. So while there has been this substantial excess cost growth, what you see if you look more closely is at any point in time, those quote-unquote excess costs are much higher in some areas of the country than others, with the cost per beneficiary varying from as high as $13,900 per beneficiary in the dark blue areas down to around $5,000 per beneficiaries in the very light blue areas. I say these are numbers that are adjusted for differences in cost of living and demographics. So this really is the residual per beneficiary cost variation, which is huge. I don't think Peter has any slides on it, but these variations have been around for decades. Dartmouth started documenting them in the 1970s, and they have grown, not shrunk, over time, despite all of the attention that's now been paid to the fact that these area variations exist. Dartmouth and CBO have both done some further work in understanding why these cost variations exist, which brings us much closer to the topics of today, which is what are we going to do about it. And if you look at the sources of cost variations, it's not in the areas of medicine that are so-called evidence-based practices, what Peter calls here effective care. We do have an increasing number of measures of quality in our healthcare system. And as you see, the care that's related to this evidence-based practices doesn't very much, in fact, maybe a little bit lower in the high-use areas than in the lower use areas. Those numbers, right at 1, means that that particular kind of care is just as frequent in the high use as the low use areas. Numbers lower than 1 means that it's less frequent in the high use areas. There also has been some speculation that use of some intensive procedures like getting an elective surgery, a hip replacement, a knee replacement, some kinds of back surgery, these very high high cost, big ticket items in healthcare may be responsible, and that doesn't seem to be the case either, not systematically. While there's not as clear evidence on the value of some of these procedures for certain kinds of patients, they don't really contribute to the variations in costs across areas. What does contribute is more subtle differences in medical practice, more of routine types of services that are definitely useful for many patients, maybe all patients, but there's not good evidence on how frequently and how often and in which patients within an area they should be used. So the number of times that patients are admitted to the hospital and how long they stay in the hospital varies a lot. The number of times and the length of stays in ICUs, intensive care units, and coronary care units varies a lot. How often people see the doctor, how often they come back to see the doctor, how often they're referred to specialists, and how frequently they follow up with those specialists. Imaging procedures and lab tests. Those are the things that vary. And you should think about here concretely as a patient with diabetes or heart disease, or the bread and butter conditions in the Medicare program are treated very differently in one way or another, not from the standpoint of major surgery like bypass surgery after a heart attack, but from the standpoint of how many doctors they see, how often they go back, and what kind of diagnostic and lab and other procedures are done. Those are the kinds of technologies and services that account account for a lot of the so-called variation across areas, and probably are an important part of understanding the variation in costs over time, and certainly are potentially large contributors to the so-called excess cost growth that Peter has talked about. This shows up as well at the level of particular providers. So we know something now about what accounts for these big variations in costs across area, and we know that it also happens across healthcare providers. Since should put a disclaimer in here, we have Dennis Cortese speaking next. This is a slide that Peter uses generally, and it's not just a free special advertisement for the Mayo Clinic, but the quality scores you can see, and these are all leading institutions, are quite good, over 80 at all of these three major teaching hospitals, these major medical centers, but they vary tremendously in overall cost per patient with serious illness, and the proxy for that that Dartmouth uses is people who are in their last 6 months of life, with much higher spending at UCLA and high spending at MGH, and only half as high spending basically at the Mayo Clinic. It's reflected in fewer days spent in the hospital, fewer visits with physicians, fewer visits with specialists, and more care delivered by primary care providers. Those are exactly those sources of variation that I talked about a few minutes ago, or I should say that Peter talked about a few minutes ago. So big differences, and I think Peter might also point out here that this is St. Mary's Hospital, which, Denny, is one of your facilities in Minnesota. Mayo has a multi-site medical operation now, and it turns out that some of the costs at some of the other centers are a good deal higher than those at the Mayo Clinic in Minnesota. This does seem to be at least partly an area-based phenomenon still. The other important thing to know as we head into the discussion today is that at any point in time, a small fraction of beneficiaries account for a large share of Medicare costs. You're going to hear more from our speakers later today about dealing with this in different ways. Certainly, if you want to try to save money in the short term, the place to go is that fraction of beneficiaries, especially those with serious chronic diseases that have exacerbations that account for a lot of the short-term costs. There are an increasing number of efforts focused on identifying those people before their diseases progress and trying to head off this high concentration of cost that way. So what Peter's tried to do in these slides is set up the fact that while our fiscal challenge is tremendous, there are some suggestions that this is a problem that can be addressed effectively. And the variations in cost at the level of areas, at the level of specific providers, understanding where that comes from and understanding the opportunities to improve quality of care gives us some paths to perhaps getting on a better fiscal trajectory. And if we can make health care more affordable by actually reforming health care, then all of our problems in health care reform, as Senator Daschle said, aiming to get affordable, high-quality care and coverage for everyone, all of that becomes much easier. Peter laid out a number of the specific ideas that CBO is investigating now. They overlap very well with the kinds of ideas that you're going to hear about today on developing better information to guide medical decisions through the development of better evidence on what works and having an electronic information system that can back it up. And can bring not just better measurement of quality into this more effective decision framework, but also cost information. Peter also talks about incentives, and think of this as financial support for better care, not just more care, not just paying based on volume and intensity, but for what we really want: better results for patients at a lower cost, better health at a lower cost. And differences in coverage design too, not just covering 80% of costs after a deductible up to an out-of-pocket limit of some kind, but benefits that are designed around supporting patients and getting the most effective care possible. We'll also hear today about delivery system reforms, things that providers can do to work together more effectively, to coordinate care better, particularly for chronic diseases where our care falls so short today. And then finally, a big component of helping individuals stay healthier and recognizing that individual decisions on their behaviors related to the health their health-related behaviors can have a big impact on health outcomes and potentially medical costs as well. Chronic disease is a huge part of this. As Ken has pointed out, 75% of the costs in our healthcare system are chronic disease related. For Medicare and Medicaid, it is much, much higher, well over 90%. So more effective management of chronic disease and perhaps preventing those chronic diseases in the first place could have a big impact on the outlook as well. But what I think Peter would say too is that while CBO is trying very hard to expand their capacity to analyze these kinds of reforms, they are still looking for better evidence. And one of the things that we see as a big role for BPC is helping to bring that evidence forward in an analytic framework that can be incorporated into major healthcare reform efforts. And again, that is why we are starting today with this emphasis on quality, efficiency, and value and getting better health at a lower cost as the first step in our BPC reform process. Finally, Peter wanted to highlight some this issue is that we've seen some new evidence coming out about it lately. There has been a huge increase in life expectancy in recent years. So this is life expectancy at birth from is that 1980 it says to 2000. I can't see the slide very well from here. So that's just over 20 years. Yep. There's an increase on average of more than 3 years in life expectancy at birth. Think about that. That is worth a tremendous amount. 3 years longer to enjoy all the things, you know, the iPods, the new technology. There have been estimates from Nobel Prize winners like Gary Becker at Chicago, who says that the value of the improvements in health that we've seen exceed the value of every other of progress in every other sector of our economy combined. It's really something. You know, having all the other progress is important, but having more time to enjoy it, more time to enjoy the sunsets and the families is especially valuable. So there's something important going on here with healthcare that we can potentially make work even better. But one concerning thing is that this increase in life expectancy has not been equal for all Americans. The difference in average life expectancy has increased over this 20-year period, with the gains for the lowest decile only about half as big as those for the highest decile, which highlights the importance, as I said earlier, of making sure that our efforts to improve quality and efficiency of care truly do go to all Americans. So with that as a framework, I will turn it back over to Senator Daschle and end my impersonation of Peter Orszag.
Mark, you make a very good Peter Orszag clone, and I think Peter would agree if he had been here. So thank you for that presentation and for setting the stage and for so much of what you've already provided in leadership at the BPC in this project. I want to just call it to everyone's attention the tremendous work that Matt Kennedy is doing. Matt is the project director, and I should have introduced him at the very beginning because he has been the real spark plug at this effort, and I applaud him and thank him for all of his effort in putting this program together. We're actually just slightly ahead of schedule, which is a good thing. It leaves us much more of an opportunity for discussion, and we will avail ourselves of those opportunities. Our first panelist is somebody that I've had the good fortune to come to know quite well. Dennis Cortese. Dr. Cortese is the president and CEO of Mayo Clinic. The Mayo Clinic just sponsored a conference that some of you I know attended. I see some familiar faces in the audience who were there just about a month ago in Virginia on this very issue of healthcare reform and how we might look at it, especially in the context of improving value and quality. But Dennis is an extraordinary advocate for many of the things that we want to look at, and has become a real student of health policy in addition to his remarkable credentials as a physician. I have come to know him largely in my capacity as a trustee at the Mayo Clinic, and have seen his passion and his intellect and his leadership on a daily basis. So we're very, very pleased that he could take time from his busy schedule to be here. And at this time, I would turn the microphone over to Dr. Cortese.
Tom, thank you very much, and I certainly appreciate the chance to talk with you all. I've been wearing different sets of hats. Can you hear me here? It's not working. I'll be wearing a couple of different hats as I give this presentation, and I will try to describe them as I change them a little bit to keep us on track. First hat I'm going to wear is as the CEO of Mayo Clinic, because in Mark's data he did show some interesting information that we have been aware of having to do with the performance vis-a-vis the final few months of life, and those numbers kind of speak for themselves, and they look good. But my observations are these. Number one, there is variation among our 18 hospitals, and we still don't understand that ourselves, but it looks to be that that variation is due to the same variation in the country, and it's due to volume of what we actually do to patients. That is the one observation I want you to keep in mind as we think about what we should do for the future. Two, the reward that St. Mary's Hospital receives for the kinds of performance that you were just seeing there is the chance to lose $29 million last year. Our loss was $29 million on Medicare for one of the organizations that happens to have a pretty good performance. Until we come to grips with the fact that the incentives are misaligned, we're going to have a huge problem in the future. Now, we need to get our costs down, but I doubt that we could ever get our costs down enough to be able to make money and survive on the Medicare reimbursement mechanism as it exists today. The Medicare loss for Mayo Clinic, this will be my last comment really about Mayo Clinic, the Medicare loss for Mayo Clinic last year and the year before was around $600 million. $600 million with a denominator of revenue for practice at $5.5 billion. So in other words, around a 10% loss on Medicare. We see the largest number of Medicare patients in the country, in all of our sites. In our Arizona campus, about 3 months ago, we closed the practice to new primary care Medicare patients for the first time. Our core value is the needs of the patient come first. We will not be able to keep our practice closed to Medicare. It's against our core value. It'll be a huge, huge problem for us from a cultural standpoint. But frankly, in Arizona and in Florida, we would be 4 or 5 times larger than we are today if we could find a way to make a 1% margin on Medicare. Because we can't make a margin on Medicare, we have deliberately controlled our rate of growth in those locations. The demand for our services is very high. That seems to be backwards in the United States market system, don't you think? I think there's something wrong that you're rewarded by having people wanting to come to see you, but you can't afford to do it. It's a real challenge. Now I'm going to shift gears. Shifting gears now to talk about the Mayo Health policy issues, and not Mayo Health policy, but the health policy issues, because we should be able to have successful organizations reap the reward of the value that they're bringing so that they can actually grow and function and provide better services. To do that, we've heard some of the numbers, and I'm going to comment briefly on the numbers, and I'm going to go up and show you some slides. First, with regard to those numbers, the numbers really reflect the spending on health care. I want to emphasize the word spending. The spending on health care is a function of many factors, but at least 2. One, the line item price for everything we do, and how many times we do those things. You all know that. But let's keep them separated, because the tactics to solve the problem varies. If the problem is just the price alone, maybe you can use price controls. Well, we've done that for since 1983 in Medicare, and look where we are today. I think we don't need to keep running that experiment. Price controls don't actually do it. You lower the payments, you get more volume. We've all seen this over and over again. The tactics to control volume is to do the right thing at the right time and the right way. How do you actually get together and generate the evidence on what the right thing to do is, and to do it as part of the whole organization simultaneously? How do you actually do the translational research to determine what is actually the valuable thing to do? And most importantly, how do we distribute that knowledge throughout the organization so that we all know what the right thing to do is? The distribution of knowledge takes in this country outrageously long periods of time. I've seen numbers up to 15 to 17 years to distribute what should be standard practice to 50% of the services that are provided. In other words, half the time when you go in and see a doctor, you might get the right advice after 15 or 17 years when other doctors have already known what the right advice is. We've got to compress that to it happens at the point of service with the click of the button. We know we can do this, but that's the potential, and that's how you attack volume. It's a whole different strategy. It's not price controls and it's not regulations. It's creating something that works, that communicates it, and that the patient and the provider knows what's going on. And if you want to generate value, meaning better outcomes, better service, better safety over the cost, if you're going to do that, you need system engineers. We got to get system engineering into healthcare delivery, looking at lean management, Toyota, scheduling of systems, how do you run ORs, how do you run emergency rooms. Nurses understand this intrinsically. Nobody else does. This is quite incredible, and I think this is another opportunity for us to come to grips. Now let's just test these few questions and then I'll show you the slides. Do we think we actually have a system? We've heard many people say that the system is broken. Many of you who know me say it's liberating to know that there is no system and it isn't broken because there's nothing to break. There is no system. If there is a system, who designed it and who can we blame for it? I'd like to find the engineers who actually designed a system. If you don't have engineers, you didn't design a system. Let's see if we have a system. President of the United States wakes up this morning, he says, who were injured or what were the near misses in the airline industry last night? Could he get that answer? You bet he could. In 1 second. The president woke up and said, who died in hospitals last night that shouldn't have? Do I know in my own organization among 18 hospitals? I'd be lucky if somebody called me and told me. But you better believe we don't, because it's all hidden. Now, we're pretty transparent in our own organization. But how can we in this country tolerate 90,000 people being killed each year by mistakes in hospitals? That's a 747 every day and a half crashing. And we don't even have a way to report near misses nationally. Can you believe this? So much for a system. We have no system. So let's design one very quickly. I'll ask my favorite 3 questions. You in this audience, you're now patients. Forget the fact that you have representation and you're intellectual and you know what to do for the future. Forget all that. You're a patient. You're all potentially seriously ill. All of you here, who would like to be, given your current health, tomorrow, would you like to go to a hospital, be admitted to a hospital, even if it's the best one in the country? Do you actually want to do that? Does anybody want to be sick tomorrow? Just raise your hand. And I would push it so far, who wants to be a patient tomorrow? The definition of a patient is somebody who suffers, somebody who endures. Do you even ever want to be a patient? So we need to design a system that actually will give you a chance to stay as healthy as you can be, live with your chronic illness, take your cancer and turn it into a chronic illness so you keep working and you keep very active. Some of you who knew Jerry Grossman when he was alive? Any of you know Jerry Grossman? Very active. The new book, Clay Christensen and Jerry Grossman's book's coming out soon. What you all don't know is that he suffered for cancer for the past 5 years. Had 10 operations. And he just lived his life to the full. And he's still contributing today, even though he's passed away. That's what we want to see. We want people to be vibrant and be able to continue to function and take their illness and make it into a chronic problem that at least they can live with. How do we do that as we go forward? And the final point is, before my slides, is that the Europeans that everybody holds up as the greatest, and the Canadians and the Japanese, and I've been advisors in at least 7 of those different countries, all have designed a system. There's actual concentrated work to design something. The political will was there to get it done. That's the biggest message to learn from all the other systems. We don't have to copy those systems. We've got 6 states in this United States that outperform the European systems. We've got 15 of them that are about equal. We've got a lot that are terrible. So we just need to learn a lesson that they did something. Now let me show you some slides and we'll move on. Thanks, Tom. Thanks for your introduction. Okay, we're going to talk a little bit now about a learning organization. What are some of the components that I'd ask you to think about, and we'll give you some specifics. The first is that there ought to be learning organizations in it. Organizations that can be real, structural, with people who are working together collaboratively on salary, like a Mayo Clinic, like a Kaiser, or they can be virtual, where physicians are linked through electronic linkages, and they could all be practicing privately. And there are groups that do this. North Texas group, for instance. Intermountain has a mixture of both. So the whole idea is to really foster the development of these types of organizations. I'd say push them. I didn't say require it. I said you foster it, you create an environment. How do you do that? We begin to expect one product to come out of this learning organization. High-value healthcare. Best outcomes, best safety, best service, lowest cost over time, not line item costs. You can buy yourself, like I did years ago, $300 pair of leather shoes in 1974. 10 years later, somebody said to me, "You still wearing those shoes? You wear them every single day." I said, "Yeah, I'm still wearing them. They're the best shoes I ever had." He asked me, "How much did you pay for those?" I said, "I don't know. I'm not done with them yet." They lasted 6 more years. $300 in those days was a lot of money. I don't know what it would be today, maybe $900 or something. But they were the best shoes. I've been looking forever to find a pair that replaces them, and I keep throwing them out in a year or two. They're all less expensive, but they're costing me more each year than my other shoes who lasted a long time cost. So it's not line item cost. Generate real value. To do that, you need to have integration and coordination. 2 separate concepts. Integration you can do with IT. How you really connect all the dots. Maybe the people are in the same buildings, maybe we're in other parts of the world. I am integrated to Mayo Clinic wherever I go with this. I take care of patients on this, I refer patients, I orchestrate the care of individuals on this device. Wherever I am in the world now, I could never do this job without this anymore. And you too. he and I are emailing at 11 o'clock at night. It's kind of embarrassing. Coordination is a separate issue. Coordination is what you all have to do yourselves, I think, for your own care or for the care of your mothers or fathers or other children. You find yourself in a position of saying, how do I get this done? We need a coordinating person. And frankly, that doesn't have to be anywhere near close to a physician. Could be, doesn't have to be. So integration and coordination needs to be part of the delivery system we're talking about. We need to focus on individualized medicine. Individual medicine, focusing on the individual. If you want to improve the health of a population, unless you can put the active ingredient in the drinking water, you have to do it one-on-one for every patient. The idea of population health just popping out of the blue, I didn't understand it when I was in medical school. You want to vaccinate a population, you've got to give the shots. Somebody has got to make contact with the patient or the person. We must focus on the individual. And with individualized medicine, that means the new science, genetics, genomics. We are focusing more and more on individuals. And this country is having a unique opportunity at the very time we can't afford it. We're going to have tons of information, but we need to progressively evaluate all that information to find the 10% that brings incremental value. And do that as a function of the whole organization, the whole learning system. And then the science of healthcare delivery. This is Jerry Grossman's term for system engineering. You can't talk to doctors and say, we're going to do system engineering. Their eyes glaze over. It means applied research. Everybody knows that's terrible. So we had to come up with a different set of terms, and we said science, and we said healthcare, and we said delivery, and the doctor said, oh, that sounds okay. I understand that. So that's what that term is. It's just a gimmick to get physicians to at least listen. And at least in our organization, it works big time. We really caught it. But here's what it is. Mr. Pratt, the man who started Cutter's insect repellent company, told this story. He got our staff engaged in about 5 minutes. It took me much longer to get anybody understanding it. He comes by, he says, we had this product. It was on the shelf. We were using DEET or something in the active ingredient. 0.001 was in the bottle. That was how much was in it. Really a small amount. Pretty good active ingredient. Dissolved in a solvent that was petroleum solvent. Sprayed it on the skin. The solvent was kind of greasy and it irritated some people. It was also the most expensive component of the product. He said the problem we had is we had a very good active ingredient, but the most toxic and expensive component was the delivery system. And he says in medicine, what you need to do is you've got tons of active ingredients, you're just not getting it to the patients. You've got to work on the delivery system. That's the science of healthcare delivery. How do we get the delivery out there? That group right there is what delivery people should be focusing on. My organization, other organizations, individuals in healthcare. We visited with the AAMC yesterday to talk to them. This kind of training has to get into medical schools. But what we need is you need some help from the outside. The payers and government can help by, one, pay for value. If we're really trying to get the value, why don't we pay for it? Kind of a unique concept. Talk about some ways to do that in a little bit. Pay for value, I want to be real careful how I define this now. We're talking about the quality over the cost. And when we say quality, we're talking about the measurable outcomes, measurable safety, measurable service. Service is measurable. You can just do patient satisfaction. That would work. Safety, simple. It should be zeros. Anything more than 0 is you're not safe. So let's make that one real easy, and that's totally measurable. And outcomes is where everybody gets all hung up. Well, let's define the outcomes. AHRQ has outcomes. The Leapfrog group has outcomes. All kinds of bodies. UHC has a whole series of outcomes. We just agree on outcomes. And you can agree on outcomes based on maybe the top 5 conditions. This is a way to start. We don't have to make this a huge process in this country. Define the outcomes. If a process step is important to get an outcome, then the process step is an outcome in and of itself, for instance. We're saying that we should be paying for those outcomes, those measurable outcomes, not for compliance with the process. We want to see what that outcome is. A compliance for a process would have been, let's control the hemoglobin A1C for diabetics that take oral agents. And that would be a really good outcome. Well, it turns out in current literature, it looks like for some patients, if they're tightly controlled with that medication, they actually die earlier. So don't take your eyes off the outcomes. We've really got to take a look at the outcomes very carefully. The purpose of process is to achieve better outcomes, but frankly, I don't care what the process is in one of our hospitals versus another hospital, or in Kaiser, or at Mayo Clinic, or in University of Pennsylvania. I don't really care about the process until I find out their outcomes are better than ours. If anybody's outcomes are better than ours, then that's our competition, because we're trying to improve care for our patients. Then I want to know what their process is, because maybe it's different than ours. Maybe we can learn something. Measure the outcomes. We have another concept here I'll throw out to you, and that is looking at how to improve the value chain. How do we improve the value over time as we provide care? I won't go into a lot of detail, but we look at this process as having 2 significant steps. But they're all in a linear upward slope. Now, it doesn't always go, well, the lightning bolt's sort of true. You get stops and starts, but sometimes they go up and they burn, they crash and burn, some take off later on. The point is, it's a stepwise function, and you increase the value when you're looking at the basic research. You define what is helpful, you translate that into practice, you apply it to practice, you communicate that on to other practitioners, you find new ways to deliver that, maybe through system engineering, that's that delivery vehicle thing, and you improve it even further. That's a value stream. We actually do this for our product lines, and we actually have physicians' names all along that board. of who's doing what. In several areas, we have gaps, and that's where we're recruiting to. We try to recruit into those gaps. So it's really kind of fun to do this. It's been an amazing process for us to see actually how much we had in place for some areas and how weak we were in others. And all of a sudden the lights started to go on and say, no wonder we're not getting some places in some areas. But we go through that whole process. These two little boxes are probably the most important thing for a national learning organization. And that is, those boxes are around that translation of what we now know is right and getting it into practice, and further off to the right, what we now know is better and improving the practice. That's what we call translational education. We are building an electronic learning system to make this happen so that everyone in our organization, including the patients, know what the whole organization knows, when they need to know it. Who are the top doctors in that particular field? What's the current recommendations, the current treatment? And we update this with reminders to the physicians at the point of contact with patients. And by the way, they get CME credit when they look at it. Saves them having to leave town. So as we look at this, individualized medicine in the value chain fits right here. It's a little more the basic research into practice. This is the new discovery, and how do you refine it? But also it extends all the way across, because you need to do individualized medicine thinking right across the whole process. Science of healthcare delivery is very much focused out on the other side, where you get that improving the delivery or the delivery product, enterprise learning system in those boxes I just talked to, and then the idea of integration across the whole process. So this is another set of concepts to let people know you can build a learning organization if you break it down in blocks and you move ahead with it. Second component that the outside people can help us with in the delivery system side of the equation, we need help from the outside. The first was pay for value. The second is insurance for all. We think everybody should have insurance. Agree with the way Tom described that. Now, shifting to the third hat. The third hat now is our Health Policy Center. It's been a group of convening of individuals for the last 2 years. We really had the desire to begin to influence stakeholders and get the stakeholders together so they could also influence each other. It's been kind of a fascinating process, and we've played the role at Mayo Clinic as a convening body. We've had 10 different sectors represented. We've had 800 people so far participating in our efforts. We've had about 400 patients who have gone in a 9-city tour who have gone on record with TV and audio tapes, and also some have written their comments. And we've had an additional 1,000 patients surveyed to give us input into our activities. Out of all of this work, 4 cornerstones have come up. And these are the 4 cornerstones that have come through the health policy effort. Now, when you look at the cornerstones, it's interesting. They cover, those are 4 of the 7 I've already presented to you. We did not direct this process. This is the way the priorities came. And indeed, I think some of the ideas I just showed you were also molded a bit by the ideas that came through the Health Policy Center. But they've come up with an idea, insurance for all, a bit favoring the federal employees' health care model, not their plan, but a model like that. Coordinated care, as I've already alluded to, the idea of value, generate value, better outcomes, better safety, better service. How do we do that? And the lower cost. And then the payment reform was to say, let's pay for the value. So those 4 concepts came up during those discussions. The action steps after our last meeting, which was about a month ago here in Washington, was to push further and get people together more talking about the insurance for all. I'll comment more about that. The idea of interoperable EMRs are necessary. We have an actual second forum coming up with IT providers. That'll be in August or September. I think it's August. The Federal Health Reserve Board type idea that you heard Thomas published about that. The Clay Christensen book will actually, I think, add a couple of more to that concept. And one would be an SEC type metaphor for the auditing of the outcomes, the safety, and the service, and the cost numbers to substantiate that this is accurate information, and maybe an FAA type model for reporting of safety issues. Very interesting series of metaphors that we've already got that exist in this country. Care coordination to reward those, and the idea of pay for value. These are action steps that were prioritized through our process that actually Bob Smolt and I, and I think Chris Gotti is here, and Bruce Kelly. Our job now is we're trying to figure out how to implement these action steps, and one of them, I guess, is our discussion today. Insurance for all, just to give you an idea of what was discussed at this. One is the concepts of a model that's like a multiple choice model with multiple private insurers. And notice most of those private insurance in that product of the Federal Employees Health Model are nonprofit insurance companies. There are a few for-profits, but most of the for-profits are not even in there. They don't participate. All the people would own their own insurance, which means transportability. That we think citizens of the United States should all participate. A role for employers is they can help individuals buy their insurance. No reason employers can't participate. A role for government is to help finance it for folks who can't afford it with some kind of a sliding scale. The insurers would have to take all patients. No pre-existing conditions, adjust for initial conditions as we distribute the money, and it actually opens up an opportunity to sunset Medicare and Medicaid. Something to think about that has been discussed. So if somebody who may be in their insurance product when they're 55, then when they move into older age, you just keep it rather than flip into another insurance product. Indeed, there's some advantage to that, because if you are in an insurance company that you're likely to keep much longer, they'll have a much bigger interest in keeping you healthier when you're 70 than they do now. They'll get their reward later by keeping you healthy. So there's a architectural design that makes some sense to those comments. So insurance for all. We had a discussion about, well, what happens if Medicare does still continue? We think if it's going to continue, Medicare has to substantively change. And we'll throw out some concepts. I'm sure these will be interesting. But first, Congress has got to get out of it. That we've run the Medicare experiment for 36 years or more, and we're where we are today. Do we really want to keep running it? When you look at the outcome of that insurance company with its board of directors, and you look at the reports that the Wenberg Group has been publishing the last 18 years, it's pretty clear. The most amount of dollars are being spent for the worst outcomes, the worst safety, and the worst service. Is that any way to really run your company? You'd probably want to change that somehow. Really, we probably should stop price controls, but there should be transparency of pricing and outcomes and safety. Payment for value. We've already discussed a fair bit of that. Let patients pay more if they choose. The federal model allows that to happen. There ought to be the ability to have coverage with evidence development. This is one of the best things I think that Mark ever put in, because it is part of that translation phase. It allows you to evaluate the new technology and define its role in practice. They haven't done it enough, but they've done it a couple of times. And then allow comparative effectiveness decisions in the benefit design. I know this could be a controversial point, but somebody's got to do that. Somebody's got to do it, whether it's the doctors making decisions or others. Okay. Pay for value, the concepts, how will we do that? Fee for service with reward for good outcomes is one. Fee for service with shared savings. Shared decision making is another option. Episode-based payments, and chronic disease coordination patients. And finally, I'll leave you with the idea that I hope that the new president, when we get a chance to walk in, I'm going to ask him these four, he or her, ask him these four questions, and hope in the next 4 or 5 years that this person will be able to say yes to each of those. And wake up every single morning and say, do we have a learning organization for health care? Are we getting better value? Is everybody insured? And are we paying for that value? So I would wrap up there, and I'm sorry I went longer, but okay. Thank you very much.
Thank you, Dennis. Thank you, Dennis, for an extraordinary presentation. I think you've described the lay of the land and have offered some very, very constructive and thoughtful ways with which to address this non-system of ours very effectively. And we appreciate your setting the tone for the conversation that we hope to have the balance of the day. So we are grateful to you, and your slide presentation for my money, was right on the mark. I appreciate very much your ideas. In the interest of time, I think we're going to forego questions for Dennis, at least at this point. I don't know how long you'll be able to stay, but
I'll be here till 2.
Till 2. So if people have questions, I would hope that you'd avail yourself of the opportunity throughout the morning and perhaps even at lunch to talk more about some of the concepts that Dennis has described. Let's go to our second panel, if we can, and I will call our panel members forward at this time. Glenn Steele, Jr. is the President and CEO of Geisinger Health Systems. GHS is an integrated health system serving approximately 211,000 members in predominantly rural Pennsylvania. He's been busy these last several weeks. He is with us this morning, and we're delighted that he could be here. Christine Castle. Dr. Castle is the President and CEO of the American Board of Internal Medicine, and she's going to discuss the evolving role of physicians in promoting better coordination of care. And Anne-Marie Audit, Dr. Audit is the Senior Vice President and Chief Quality Officer for the New York City Health and Hospitals Corporation. She will discuss the importance of improving quality and value for care delivered to underserved populations. The theme of this particular panel is empowering health professionals to improve care. We couldn't have 3 more qualified people in this field to help lead the discussion. We're delighted they could be here, and we thank them for coming. And let me begin by calling upon Dr. Steele.
Senator, thank you very much. Mark, you want to give my talk? And if Dennis is still here, we have a system and I'm accountable. We basically want to make a couple of points in this presentation. First of all, there really are a number of systems out there that are innovators, and we need to learn from them. Secondly, I think we're developing data showing that innovation in healthcare delivery, major innovation, actually helps citizens, not patients, but citizens, and we're getting more and more evidence that it saves money. So quality and value are actually linked in some of our experiments that I'll summarize for you. And we think that there's an interesting idea about how coverage for all, or expanding coverage, might be linked directly to incenting better delivery. It's a lot easier if you're adding something to change the incentives than if you're perceived of as taking something away or diddling with incentives that have been there for many, many years. So I just want to propose that to you. Senator, we cover 2.5 million, and the 210,000 that you mentioned is the insurance component. So the provider component of our system is much bigger. We're in the T of Pennsylvania. We've been very busy until yesterday. Now we can get back to work. And the blue part of the chart is the insurance market, and then the 3 circles are the provider component. We deal with about 15 hospitals that are not Geisinger-owned hospitals, where we account for 50% or more of the volume. This is rural or post-industrial. And it's a very interesting, very stable market, sicker, older, and less wealthy than almost any average market in the country. We have 55 sites. 40-some sites are community practice sites that vary in size from 2 physicians and a mid-level to 15 or 20 physicians with specialists. We're completely electronic. Have been electronic since '97. And we've opened up to about 1,300 non-Geisinger physicians so that they have web-based portals with read-only for patients that we share. So it's an attempt to move towards a regional approach without necessarily co-opting or preempting or buying folks that are in private practice or acquiring hospitals where we treat our patients. 84 and 80, the 2 interstates, incredible expansion in the northeast, very static in the middle, the yellow circle, and in the west around State College, an intermediate demographic, good growth, a hub-and-spoke arrangement, lots of folks that can be treated with even early tertiary care out in hospitals close to where they live, with patients coming into those STARS, which are our hubs, for late tertiary and quaternary care. So it's an interesting idealized design. For about 30% of the business that we both provide care for and insure, we've committed to transformation, innovation, experimentation. And what we're trying to attack is what we think are the core problems with our health care in this country: unjustified variation, fragmentation of caregiving, payment incentives that are based on units of work as opposed to outcome, and patients as passive recipients of care, not as active participants. So we think that these are addressable. We're not sure that these experiments are uniformly successful. I'd like to talk to you in a little bit of detail about our medical home definition and some interesting results in terms of the chronic care patients, and also proven care, which is the acute episodic bundled care, including our taking financial risk for complications. In the written material, Senator, that we gave you, there's some interesting data on chronic disease care optimization. The medical home experiment is very interesting. Our insurance company basically pays for nurses that are embedded in our community practices. And each nurse takes care of 125 of the patients that are the highest utilizers over the last couple of years. That is, the sickest patients. They have on average of 5 chronic diseases. And they give 24/7 continuum of care. And they basically function in a way that that maximizes not only the care for the sickest patients, but they also help to redesign the practices. We wouldn't be able to do the kind of management of these patients that we do without having this enabling technology with HIT. These nurses now are incredibly valued by our physicians. Probably the most positive thing the physician can say about the nurse embedded in the practice is they don't even think of them as insurance company employees. We've now taken this out to about 13 of our sites, including a couple of non-Geisinger doctor sites. And the kind of effects we've had on hospitalization rates for chronic disease patients, and again, these have on average 5 chronic diseases, have really dramatically decreased over the first 18-month beta test on this. You can see the numbers for yourself. Rehospitalization is equally impressive. Absolutely incredible changes. Now, it's 18 months. Questions are, is this durable? Are we pushing these people out to SNFs? We have all that within our system, so we can analyze that. We have no evidence yet that we're kind of just moving the disease around. We think that this care is based on fundamentals. The most important thing for the readmission success here is making sure the patients and their families know the medications that should be taken and when they should be taken. It's pretty basic blocking and tackling. But we are amazed at how ineffective that's done outside of a system type approach and outside of an incentive that is an obvious incentive for the insurance company here. The return on investment, as you might imagine, for our insurance company in better treatment of these patients is immense. So whatever the cost is for embedding the nurses, it's going to be a high yield very, very quickly. As I say, this is being expanded out. If you extrapolated this in any sort of a conservative way to Medicare admission and readmission rates, you could do the numbers. And I'd like to end by giving an example of an innovative approach which we started a number of years ago. Looking at high-volume inpatient procedures, we started with elective coronary artery bypass, and we determined best practice. This is off-the-shelf, discipline-based consensus or evidence on everything from diagnosis all the way through to rehab, outpatient, inpatient, outpatient again. We were able to coordinate in our system with employed physicians and doctors and physicians and insurance company working together, the fact that we would re-engineer our program. We basically looked at our historical complication rate and we said, let's, in the bundled price, do a 50% discount on that historical complication rate. So we would have to do better than a 50% improvement in order to make any money on this in the negotiations with our insurance company. When we started, we were already probably in the top 2 or 3 of the high-volume elective heart surgery programs in Pennsylvania by PHC4, Pennsylvania Healthcare Cost Containment. But as you can see, we could really improve on hitting those best practice bogeys from beginning to end. And so it's about 50 bogeys. We could not have done this without the electronic enabling. We're talking about things like precisely starting antibiotics on time, precisely stopping antibiotics on time, precise corridors for appropriate temperature of the patient when the patient left the operating room going to the recovery room, precise values of blood sugar with insulin drips, all of which, either by evidence or by consensus, were felt to be associated individually with best outcome. And what we saw here with this first relatively straightforward beta test was obviously no harm done to the patients, and the indications of some significant improvement in quality. And the most intriguing thing is the numbers that are starting to be generated in terms of value. If we could take half a day off of an already short length of stay for this group of patients, we're going from really pretty good outcome to start with to even better outcome and significant value. And the discussion right now is where do we give this value? Is the value going to be distributed to the providers? Or does some significant part of this value have to go back to the buyers? And since our insurance company is trying to sell this product, we've got to give a lot of this value back to providers in lower premiums. And that's at least an interesting conversation that's based on some initial evidence that we can produce value here. We've expanded the portfolio into a series of other high-volume hospital-based treatments. EPO, there's an interesting example, just want to mention to you. That's erythropoietin, which is used for chronic renal failure and for various treatments in cancer or blood conservation for elective surgery. When we have applied this kind of best practice algorithm and a centralized management to the use of EPO for all of our patients with chronic renal failure, we've saved on average of $4,000 per patient. And we've moved those patients away from the high probability that the overuse of that product actually causes significant complications. So we think that's an interesting paradigm for biologicals in general. Policy implications, again, I would want people who know more about policy than I to think about linking coverage for all, and we agree with that, to changing the incentives in the delivery system. We think that payment for acceptable outcomes, not bonuses for acceptable outcomes, I might add, but payment for acceptable outcomes only is scalable if Medicare is used to lever. Now, the essential predicate of Medicare was not to affect health care delivery. That's the way the law is written. And what we're suggesting is it's a different time, and we really need to rethink that. And we believe that only systems like ours or virtual integrated systems, and as I said, some of ours is virtually integrated, can deliver this kind of innovative care. And we think that HIT is a critical enabler for achieving some of this innovation. So thank you very much, Senator.
Thank you, Dr. Steele. Thank you, Dr. Steele. I think we'll hold off on questions until all three of our panelists have made their presentation, and we'll go now to Dr. Castle.
Thank you, Senator, and thank you, Chris and Mark, for getting this together, and Matthew for the communications, and especially Chris for those late-night calls. which
You got them too, huh?
oh, yeah. And I actually, as somebody who organizes meetings a lot, I really do appreciate it because it does help focus on what's most valuable for this group. And so I just wanted to let the attendees know that there's a single-page document on the outside that has kind of a summary of this new set of slides, which is not the same as the original one that I sent. But it does start with this cartoon. So I'm talking from two perspectives. Many people here have been wearing several hats, and one of them is my day job, president of the American Board of Internal Medicine, one of the independent standard-setting organizations for medical specialties, which do have a major role, often less appreciated in the American healthcare system, in evaluating 87% of the doctors who are medical specialists in the United States. This is a tool that is now increasingly aligned with other kinds of evaluations, pay for performance, and provider reporting. So you'll be hearing more about that. But I'm not speaking today for ABIM, at least largely, because this group, what you're doing is so important. I wanted really the ability to say what I really think, and so I'm just warning you, that's what I'm going to do. And I want to endorse what's gone before, certainly Dennis Cortese and Glenn Steele's urging that any thinking about healthcare policy reform has to not only think about financing, but also think about delivery, that really goes hand in glove, and then that 1965-66 Medicare language really is obsolete. We're dealing with taxpayers' dollars here, and it's the delivery system that really is what delivers care. So there are a lot of doctors who don't like being called providers, which is why I show this cartoon. But actually, what I think we need to do is I think we need to refashion the physician's job description to become a provider, and to take seriously the knowledge of systems, and to not have the problems that Denny talked about trying to sell doctors on why systems matter, but actually have that be an inherent part of our education and our accountability. So what's needed at the physician level is, first and foremost, an awareness that there are other people in the healthcare system. We've heard a lot of talk about nurses. Nurses are vitally important, but so are a lot of other people. To be members of a team that coordinates and integrates care. Senator, you mentioned your perspective as a pilot. Certainly pilots understand that a single pilot alone in a plane has to rely on the mechanics, has to rely on other people who manage those teams, particularly in those larger aircraft. We also have to be providers as well as users of meaningful and valid quality and cost information, and we have to do our part in managing resources and controlling costs. It isn't just what physicians get paid that is a major part. That accounts for actually about 20% of healthcare costs. But many people, I think Ken Thorpe is one of them, have said the real expensive item is the physician's pen. And now it's, of course, the click and the computer. It's what you order. It's all of those tests and the volume or more judicious use of all of the things that physicians order. What this needs in order for the physician to become the provider is a different skill set. And I would argue we're actually at risk of losing a core skill set because of the loss of what's called primary care. There's another article out in front that I urge you to pick up called Redefining 21st Century Primary Care that argues for a much higher bar for what it takes to be a primary care physician because of the needs of that smaller percentage but very high utilizing population of people with chronic illness. So we have a lot of assets. The glass really is half full, and we do have to remember when we talk about all the problems facing the healthcare system that we do have a lot of good things and good things to work with. And I think, Mark, you pointed that out in terms of life expectancy. We have a growing evidence base about what really works. We ought to use that more. We do have well-trained and motivated healthcare professionals who just need to learn how to work more in systems. The Geisinger and Mayo models are ones we really ought to be emulating. But there are others as well, including international lessons that we can learn, as I think Dr. Cortese mentioned. We need to find ways to reward more effective practitioners, and I think a lot of the current pay-for-performance models are really rudimentary and are ending up getting us both confused physicians, but also, frankly, the evidence suggests not necessarily the results we really want. So you need to enlist the physicians as your partners in this. Most of the physicians I talk to really do feel the system is broken, or maybe even there is none, but that they have to make it work for the patient who's in front of them, and so create these ad hoc systems that are often very inefficient and ineffective. What are then barriers at the physician level? You've heard about this, and I'll just reiterate that I agree. It's this fee-for-service reimbursement based on volume of services rather than on taking responsibility. And that's a word, I think, that at least I prefer to accountability, but they both mean the same thing, taking responsibility for the care of a patient. And how do we pay people for that? Geisinger and Mayo, they pay people by salary. Maybe that's a model we should think of more with more appropriate rewards and accountabilities. It certainly does not support, outside of integrated systems, a practice infrastructure, not just HIT, but teamwork within those structures. And from the perspective of the dying specialty of primary care, it really has exacerbated this disparity between generalists and specialists. And I can tell you from my perspective, overseeing this large specialty of internal medicine, that we now have 80% of students who go into internal medicine choosing subspecialties. And of the 20% left, more than 10%, more than half of those become hospitalists. So you have actually about 8 or 9% of that primary care, of that group going into a primary care discipline. So by the time we figure out medical homes and other options, we may then need 10 years to train all the people to do it. So we do need, I think, to be urgent about that sense of defining primary care and defining a way to pay for that. I know the MedPAC upcoming June report will address that. Oh, what did I say, MedPAC? Is that what I So I mentioned pay-for-performance programs. I just want to point out that soon-to-be-released data from 10 years' experience in England with pay-for-performance using single-disease clinical measures as targets actually shows the same thing the VA program showed, which is that you do improve on those diseases, and you actually don't improve or do worse on the things that you haven't measured. So when you're talking about complex patients with multiple illnesses, who's going to be measuring the Alzheimer's disease component? Who's going to be measuring the osteoarthritis component? So we need to really think about how do we measure and reward a more comprehensive balance. There is good research going on in this area, but it does mean that we need to use current pay-for-performance models with real caution. So I think we do have good evidence that the current system is not going to support this kind of coordination that we need. What are some policy approaches that are out there? And I do want to address the medical home idea, because you've heard that from Glenn, and I'm sure Mayo Clinic would claim, and rightly so, that they have a medical home model. This is a hot item right now because purchasers, insurance companies, and Medicare have landed on this idea with some hope that you can assign a medical home, a medical practice, responsibility, use that word again, for managing and coordinating the care of patients with complex illness. There's a lot of good reason to think that that will work. If you look internationally, there are models that show that that will work. If you look at places like Geisinger and like Kaiser, that's exactly what they do. They look at that high-risk group of patients and create a coordination around the group of those patients to reduce unnecessary utilization, reduce complications, and improve outcomes while spending less. The problem is, with both the Medicare demonstrations and with the current private sector discussions and demonstrations that are going on, is that it hasn't yet been figured out and, frankly, politically negotiated how to target the patients where you really need this and where you're going to get the payoff, and how to create a high enough bar for the providers who get these extra payments, however they're structured, so that they really have the skills to manage that care. Because it's never going to work if you just call everybody a medical home and you don't have any standards for that. So I just would urge all of us, as we think about those models, to keep those things in mind, and I think the MedPAC report is going to address some of those issues as well. There are other models. There's a Massachusetts model of a salary plus bonus in a physician practice, the ambulatory ICU, that the Mercer experiment with in Atlantic City and Las Vegas is one that has multi-tiered, very elaborate use of nursing personnel, and other models around the country. But the concept is the same one. You take the patients who need it the most, and you have providers who actually are willing to take responsibility for them. And then finally, let me just recommend some approaches, and here I put this on the table because I really do think this message about it's time to think in a new way about Medicare. Maybe Dennis is right, maybe we can, just walk away from it over time and have more like a German model. But as long as we have Medicare, we have taxpayer dollars that are going for health care, and they need to be used in a responsible way. So we talked some about the need to, and I think, Senator Daschle, you mentioned that too, to create a bundled payments or something other than this fee-for-service kind of widget model of healthcare where the more you do, the more you get paid. Another way to do that is to create accountabilities. The highly paid specialists actually are not required to have any responsibility to the primary care doctor in order to get paid for what they do. The primary care doctor does all the paperwork, and the specialist gets all the reimbursement. We could turn that around. We could say, we're not going to pay you, Dr. Specialist, until the report goes to the primary care doctor. Simple things like that could really be thought of. That's what happens in these integrated systems already. Doesn't happen in the non-integrated world. Take seriously the opportunity, and frankly, I would argue the responsibility, to overhaul the RUC and the RBRBS system. That was put in place same time, 1965, 1966, but it doesn't serve its purpose anymore. It is a misrepresentation of the medical practice world, quite frankly, and it also, in the current day and age, ought to involve consumers, it seems to me, in setting those standards and those relative values. And finally, seriously incorporate comparative effectiveness in that. I understand that's been a hot political button, but I don't know why. It just makes sense that we would compare what works, what doesn't work, and pay for what works. And then finally, as we think about all this measurement for accountability, we have to remember that most of us in the provider world weren't really trained in the quality improvement science that the rest of systems engineering and systems industries have done. We need to learn these lessons, and we need to gain tools and help in understanding, once we get these report cards and understand where our gaps and shortfalls are, how then to improve those. So broaden assessment and improve accountability, but also really invest in measurement that means something to the provider as well as the consumer, so they can understand it, and then also so they can act on it. Thank you.
Thank you, Dr. Cortese. Thank you, Dr. Castle and Dr. O'Day.
Good morning, and thank you for the opportunity to be part of this discussion on quality and value in our healthcare system. This morning I'm representing New York City Health and Hospital Corporation, as well as our member organization, the National Association for Public Hospital and Healthcare Systems. And what I'd like to do is tell you a little bit about our transformation and how in our public hospitals we've been able to tackle the issue of quality and value, discuss with you some of what we've accomplished, our challenges, and some of the policy implications. HHC is the primary public hospital and healthcare system in New York City. Every year we see 1.3 million New Yorkers in our facilities, 1 out of 6 New Yorkers, and 400,000 of them are uninsured. We care for a very diverse patient population. Over 100 languages are spoken by our patients, and 43% are Hispanic, 35% are African American, 6% Asian, and other minorities. And they come from a socioeconomically diverse and socially complex patients. HHC is one of over 100 urban safety net health systems nationwide, and our goal is to provide comprehensive care in our communities. We provide this care through, we are a system actually. We try to be a system. We provide care through 11 acute care facilities, 4 skilled nursing homes, diagnostic and treatment centers, and over 88 community health clinics. We also own a certified home health care agency as well as a managed care organization, and our employees are over 40,000 employees, physicians, and about 8,000 nurses. About a decade ago, HHC really underwent a transformation to really look at how we could provide quality of care, and the vision was that the system would bring value to the health and healthcare in New York City. This has been done through looking at many different areas, through our governance and leadership, through developing a culture that is just, safe, and transparent, and I'll be talking a little bit more about that, through developing some incentives to promote safety and quality, and through really tackling very seriously the re-engineering of our care processes. And it's all about our patients, about people. So we've developed a very robust performance improvement infrastructure, how to use effective use of information technologies, using teams, and another area that's come up in all of our panelists today is really how do we provide coordinated care across our services, across our sites of care for our population. The clinical strategic priorities are very clear for us as a public hospital and healthcare system. We need to ensure the care continuum for patients and for our community. So that means services so that our patients can stay healthy. That means preventive services for patients to get better when they're sick, providing acute care services, to help our patients live with disability and chronic conditions, and also to help our patients cope at the end of life. So those are of our patients that are in skilled nursing homes or palliative care services. And we keep our radar on the very well-known quality dimensions that the IOM has proposed so that our patients have access to care in a timely fashion, in a safe way, patient-centered, cultural competency, and we need to be efficient, and I'll talk a little bit more about that. So let me focus in 2 major areas this morning, and that is our transformation that included our transparency and how in our system we try to foster collaboration and healthy competition. And the second one is how we went about re-engineer our care processes to really address the need of our patient population, which, as I said, is very clinically complex and socially complex. So first, our transparency initiative. HHC has capitalized on a unique opportunity to inspire collaboration and sharing of best practices and healthy competition among our over 100 care facilities and to drive quality improvement and accelerate the pace of change within our healthcare system. All of our facilities report into a very systematic and comprehensive dashboard of performance indicators. And we actually have a Quality Assurance Committee of the Board that is chaired by the health commissioners. So that means we have a very integrated public health as well as healthcare approach in New York City. And this happens, those indicators are reviewed actually on a weekly basis. And that allows our leaders to identify trends and to set actions to address those trends very specifically. So we're able to be more effective and efficient by focusing our actions towards the trends that we identified. In September 2007, we issued our first public release of performance information on our website, which is called In Focus. And if you go to HHC and you Google HHC, you will see our In Focus and our set of indicators. Initially, we provided the acute care and some long-term care indicators, and next week we're going to be releasing our second phase of performance measures, and here is to really mirror the comprehensive set of services we supply to our patients. We'll be adding preventive care measures as well as measures on how well we are doing in chronic disease management. We believe that this is also what our patient and the public wants to see on our website. Here I show one example of what we have here, which is we look at our corporate performance on central line infections, and we see trends over time that we've been able to reduce our central line infection by over 50% over the past 3 years. But we also show, because we are a system, facility-specific information that really shows you a range of performance. So we have variation within our system, but by showing this information, we can really, first of all, start to benchmark internally, find the best practices. But we also show that we are very serious about not only showing how well we're doing, but also where we need to improve. And those types of, that transparency keeps our leaders on their toes, and as well as promotes a little bit of, that's what I mean by healthy competition amongst our facilities and providers. Let me now turn to the strategies that we've put in place to improve safety, quality, and efficiency in our system. Again, here our goal is to ultimately provide a comprehensive set of services to our complex population. So that's really what we keep ahead of us, is who are our patients, who are we serving. As a learning organization, we provide learning and collaboration for all of our staff, for 40,000 staff, so that they are aligned and really understand what our quality and safety goals. So that permeates our entire organization. And we also, our performance improvement activities really rely a lot on team-based collaboratives. And we have team-based collaboratives in many different areas, infections, diabetes, and we rely very much, as many of our speakers before me have mentioned, on the chronic disease models. Through our system-wide collaboratives, we have improved the coordination of patient care by increasingly using care management teams. Instead of our patients seeing their physician one-on-one occasionally, we really now rely on teams that regularly impact and touch our patients. That include patient navigators, nurse care managers, as well as community-based workers that outreach to our patient and ensure that patients are engaged with their own health and also keep engaged with our healthcare system, so we do not lose them. This is very important to us. We also try to use our information technology very effectively. We've had a centralized, system-wide electronic medical record for over 15 years, and we try to embed in those intelligence and decision support at the point of care. So many of our speakers have mentioned appropriateness of care and standardized clinical guidelines. In our medical records, we provide those standardized protocols for our physicians, so when they're seeing their patients, they know exactly what they need to do, and they're prompted to help them make decisions. We also are very much facing the challenges of interoperability because our patients go from site to site, and we have some pilots in Queens where a number of our patients have smart cards, and whenever they appear in any emergency room in any of the hospitals in Queens, the providers have access to their health information. And we rely heavily on patient registries. Our registries cover about 50,000 diabetic patients at the moment. Another important aspect of our redesign was ambulatory care, so that we provide access to our very complex population. And this has been going on for about 3 years, and we've been able to decrease our no-show rates by 50%. Our cycle time for our patients in our clinic is less than 60 minutes for most clinics, and we've been able to decrease our wait time for an appointment by 4 to 5 days. We also co-locate specialty care services in our primary care clinics, and that's been very, very important to assure continuity of care and access to specialty care for our patients. And finally, just a word on efficiency. As a very large system, we also have to be very efficient in how we use our services. And as of 2008, we're starting on a breakthrough initiative that is corporate-wide based on the Toyota Lean thinking. And again, our vision with this is to better allocate our resources to patient care needs and to bring services closer to our patients. So I'm going to close by a few slides on the bottom line. I think that we, as a public hospital and health care network, we've been able to demonstrate some value for our patients in New York. We've improved performance in preventive, acute care, chronic, and long-term care settings. In our acute care, our in-hospital mortality has continued to be lower than national average, as well as our hospital-acquired infections. Those are outcomes. And then we also have process of care measures, the CMS indicators, and there we also outperform national performance on many of these. But we're really focusing on the outcomes here and not on the processes. In terms of long-term care, we've been able to reduce our pressure ulcers in many of our skilled nursing facilities by 50%. Our falls are also decreasing and much lower than New York State average. In terms of our chronic disease, I'm showing you some indicators here that you will not find on many public websites. We were really very focused on preventive care, and here we show smoking cessations and the fact that we now have a 51% quit rates among our patients in New York. We also have data on our pediatric asthma hospital admission rates that have continued to decrease over time, as well as in the adult population, which means that we are managing these patients very well in the ambulatory care setting. And in terms of chronic care management, here's some data on diabetic care. The process of care here, 91% of our population has been screened, but that's a process measure. We don't only care about that, we really care about the outcomes. Now our outcomes, which are control of blood sugar, cholesterol, and blood pressure, you see that we're doing less well. But we have our eye on it. This is going to be on our public site, so we really care about that and are continuing to make sure that we improve on these indicators. Our challenges are achieving and sustaining consistent performance. We have pockets of excellence within our system, and how do we broaden that to the entire system? How can we get to the reliability to get the right care for the right person every time? And that, a lot of speakers have mentioned that. We need to hide wire. We can't just exhort providers to know and to teach. We really need to hide wire, and that needs more resources. And the next area is, of course, we're all struggling with this, the coordination of care of our patients. I'll end by policy implications. Several of them have been made by previous speakers. Supporting new models of care. We can no longer rely on the traditional one-on-one patient care visit. We really need to be able to support multidisciplinary teams of physician, nurses, community-based workers. And we need to design payment policies to approach these new models of care. And I think the medical home is one such model, and there are other models around that have similar intentions. For the public safety net, it's really important that we look at how we can provide the required tools to achieve high performance for our patients. Health information technology is very important in terms of hardwiring and making sure that we have the decision support. Now, we've been blessed with having information technology for a decade, but we're now having to go to a whole new system. Our system is no longer going to be able to support what we need. So that takes resources, and how do we, again, finance and support information technology for other safety net providers? And then the technical assistance for performance improvement and redesign is also very important. It doesn't happen by magic. And finally, incentives. 2 points here. First is that quality reporting and payment policies need to capture the care services of all patient population. As I mentioned, our vision is that we provide services for prevention, acute care, long-term care settings, and we need to, again, look at outcomes and how we're doing for our populations. And finally, we need to break this cycle of supply-driven healthcare and reward providers for improving public and patient health outcomes, and I think I've also heard that comment from many others. So thank you very much for your attention.
Thank you. Thank you. Thank you, Dr. O'Day and Dr. Castle, Dr. Steele. We're very pleased that you've shared such compelling information with us this morning. Unfortunately, our schedule is quickly getting away from us. We're over schedule at this point, so we're going to forego questions. I hope that you'll be around to accommodate questions personally throughout the morning, if that would be acceptable to you. But I think we'll move to our next panel to see if we can't. And I thank our panel for excellent presentation.